absence of Councillor Elsie. Can I ensure that all councillors have access to the agenda on their laptops, please? Thank you. Welcome all committee members, members of the public and press, and those viewing on the live stream to the meeting of the Adults and Health Scrutiny Committee. Just like to remind everyone that this is a public meeting and that the meeting is being live streamed. Just to let everybody know that in the event of a fire, everyone should vacate the building through the nearest exit, which is through the reception area, and proceed directly to the assembly point, which is in the open area opposite the car park. I would like to now ask all members to introduce themselves, starting with Councillor Boyce, please.
Thank you, Chair. Parish Councillor Neil Boyce, Co-opted Member.
Parish Councillor June Ball, Co-opted Member.
Brian Tyler, it's a bit hard. Brian Tyler, Gunthorpe Ward.
Councillor Ishfaq Hussain, Dogsthorpe Ward.
Councillor Saqib Farouk, Glinton and Castor Ward.
Councillor Chris Burbidge, Bretton Ward.
Councillor Scott Warren, Bretton Ward also.
Paulina Ford, Democratic Services Officer, supporting this committee.
Charlotte Black, Director of Adult Social Care.
Jyoti Attry, Director of Public Health.
Councillor Barkham.
Councillor Ansar Ali, North Ward.
Councillor Shabina Asad Qayyum, East Ward.
Councillor Sam Hemraj, East Ward.
Thank you very much. I'd just like to thank Councillor Hussain for substituting for Councillor Halsey tonight. Thank you very much. Apologies for absence.
Thank you, Chair. As you've just stated, we've got apologies for absence from Councillor Elsie, and Councillor Hussain is attending as substitute. We've also had apologies from the Health Watch representative. Although he's not a member of the committee, he wished to submit his apologies. Thank you.
Do we have any declarations of interest and whipping declarations?
Councillor Hemraj, I work for North West Anglia Foundation Trust, so when they present at this meeting I will be making an exit during that part. Thank you.
Thank you. Minutes of the Health Scrutiny Committee meeting held on the 21st of September. Do committee agree they're a true record? Yeah, lovely, thank you very much. Do we have any calling of Cabinet or Cabinet member or key officer decisions?
There are no call-ins for this evening's meeting, Chair.
Agenda item 5, the East of England Ambulance Service NHS Trust, report on progress on CQC inspection target and overview of performance in the Peterborough area. Marcus Bailey, Chief Operating Officer. Thank you.
Good evening, everybody. Good evening, members. Obviously, we've submitted the paper in advance, so if committee would allow me for a short while just to give some summary and salient points, then I'll hand over for questions. Thank you. I just wanted to set the scene in to say that the last 12 months have been extremely busy, both in terms of addressing the CQC actions, the actions from the EHRC, and more recently the findings from Ofsted. Within that, operationally and for our patients, a really busy 12-month period, reminding that COVID has not disappeared, and the busyness as we now move into winter from the summer, placing a significant amount of pressure and strain on our ability to deliver the service, enacting a number of contingency plans within there. Just to give a flavour and set the context, from the CQC we had over 170 identified actions in order to address the regulatory concerns. Those actions are now fully or partially completed over the last 12 months, and we now prepare for the CQC with regards to a whole inspection against the key lines of inquiry and service lines. When the CQC came to visit us, this was very focused and a focused inspection on well-led. That led to the trust being placed into special measures, or as it's now known, the recovery support programme. And within that, continual work really to progress in some, I'd say, some basic areas which sound basic but complex, in encouraging people to speak up, speak out, and supporting people, our people, to have the confidence and the trust in order to do that. What does that translate to so far? Recognising our journey is far from over, and we are into, in effect, the first year within this. It's resulted in over 2,000 interventions of a cultural and employee relation nature, and that ranges from coaching, it ranges from encouraging people to be able to speak out, it's support in terms of the individuals in the workplace, manager kind of discussions problems, so really high numbers, but in a positive way of being able to speak up. And then the last kind of bit I just wanted to lead into was really around the ability for us to start looking at more sustainable, more kind of embedding, and for the future as well. And all of those steps in terms of 5 key themes that we would look at in order to be able to do it under what's known as the Fit for Future programme. And my last point before I hand back, Chair, is I just wanted to say publicly a big thank you to our staff and volunteers who've worked tirelessly through COVID, through winter and into the summer as well. Thank you.
Right, thank you very much. Councillor Kyan.
Thank you, Chair. Thank you very much for your report, and thanks to all of EEAS from us for their very hard work at such challenging times. What I'd like to ask you, I'm particularly interested in point 5.0, other projects and processes with the body-worn cameras. Now, in view of patient confidentiality, are patients aware, or is it declared, that body-worn cameras are going to be activated, or are these only reserved for those incidences whereby an ambulance personnel may be at risk of assault? Thank you.
Thank you for your kind words. Yes, absolutely, the latter part. So this is, in effect, what I would describe as a rescue or extreme. It's activated by the member of staff if they believe they're in a difficult or vulnerable situation. They will be identified and they will be visible, but it's not continuous. It would be in terms of responsive.
Thank you very much.
Councillor Barkham.
Thank you, Chair. Excuse me. I've got a few points I wanted to raise with you. Can I do them all together, or do you want to do them in?
Yeah, you do them all together.
Yeah, okay, thank you. Hi, Councillor Barkham. So, I suppose we could look at this in a linear fashion. So, in your own words, once I've got through my little bit here, if you can just share with us how it got to this position, where Ofsted had to come in and we was awarded with special measures. What then is the plan going to be to prevent that from occurring again? So not only are you getting out of special measures, but what are you going to do to future-proof that so you don't go back into special measures, for example? Also, if indeed there is another pandemic, how would you cope with that? Also, on the improvement programme, which is section 2.0, page 15, with relevance to 2.1, on sexual harassment, there's a brief paragraph where it says, part of the report highlighted concerns many staff had raised about experiencing sexual harassment, but there's no further elaboration on that subject. Can you just unpad that a bit more with regards to what's actually been done with regards to sexual harassment, and to reassure us that people can indeed come to somebody without any recompense for whistleblowing, as it were? Thank you.
And thank you for the questions. Please, if I don't address them, I've tried to write them down, please do just flag and I will go through those as well. So if I start with the how did we get there question, I say a really good question because it's one we've been asking ourselves as an organisation. So not just in terms of sorting it out, not just in terms of moving forward, but in the part of it, you need to understand why you and how you got there in the first place. So rather than trying to give a true politician's answer in there, in the sense of multifaceted, it is. But actually, if I break it down to a few bits, leadership is one of them. Absolutely leadership, and what I mean by that is it's recognising and were we asking the right questions. So this notion of being curious in the questions, does the data help us? Are we reading behind the data in terms of numbers? Are we triangulating evidence and understanding? Did we recognise when you pulled things together, that triangulation of, if you look at sickness, if you look at casework, were we sensitive enough to kind of the risks within the organisation? There's a big piece around stability, or as it was, instability within the senior leadership team, with a number of temporary posts within there as well, and a number of changes within that. I think it's also about how the organisation, and this has been part of the board development, which kind of links into your next question, that while this is at every level, and I think when you ask about sexual harassment, to talk about that, is that there is absolutely an ownership at board level. Absolutely, there has to be an executive level, but some of the cases we are dealing with, these are staff on staff cases. So there is a multitude and a range of those areas that says this is at every layer in the organisation that we are having to address and having to work through, and being well led is a key component of those as well. It's also about the balance in terms of some of the business priorities. So the ability for us to look, and I think the way we're describing it to ourselves at the moment, because this is really important, that you can't run before you can walk, and you can't fix everything all at one go, because it's just actually not possible. And the risk is that you try to do a quick job, not a job that's going to help you. So we're looking at the term fix, embed and sustain, and the key bit coming into is the sustainability in that. So if we address issues and they are kind of deep, and we need to be able to do that in terms of recentering and rebalancing behaviours, values and civility in the workplace. If we look at encouraging an environment that enables people to speak up, speak out, and for us to stop it, then it means we're in a position to be able to put that embedding and moving forward, because actually it's the cultural change that comes from all of those activities within there as well. From a do we know it's working? Look, it's definitely not fixed, and I'm not going to come here and say it's all fine. It's absolutely not. And we will take 2 steps forward some days, and what feels like another step backwards on another day. But actually, what it's showing is some of our systems and processes where people are able to come forward. That's a real testimony. If I look at and link back to the Ofsted, kind of when Ofsted came in and the follow-up piece of work we've done, we've been able to see and have conversations with all of our learners who wanted to have individual meetings with a line manager. That's over 600 individual meetings, and from that we have learnt so much about the organisation and also issues that we've dealt with as well. Now, roll back 12 months ago, do I think 600 people would have been open and had a conversation with a line manager? Probably not. So actually that's a really positive step. For our Freedom to Speak Up Guardian, when we look at last year compared to where we are now, it's a 900% increase in people contacting our Freedom to Speak Up. Now, statistics always, it sounds that, but what it says to me is that people know how to access our Freedom to Speak Up Guardian. It's a confidential process, and people are making use of that where we're looking to resolve. The other side is also in terms of where people are viewed or we're supporting as whistleblowing, and we are supporting cases now where people are and maintaining anonymity. We are using it with regards to the whistleblowing. So actually I would say in terms of the first step is, do people trust us to speak up? We're seeing that now, and that for me is such an important element, because again, if we get the metrics and everything I'd said right about how do we get there, then the making sure it doesn't happen again is absolutely having that relationship with our staff, our people, with each other, and really changing it. In the context, this, for us to say we're fixing and embedding and then true sustaining, we're looking at leadership development, which is a 3-year pathway to be able to get some of these steps in. This will not be done overnight, and this is almost getting that absolute, we need to fix the fires now, we need to put those out, but we do it in a way that get some of those underpinning elements within there. And I have to say, summarise again, behaviour, trust, civility in the workplace, they are the main things that we're focusing on. If I then link into, that's okay, into just sexual harassment and just pick up a bit more in that, we have, I think we made a decision very early on to support people with the ability to speak up, to not necessarily put loads of detail about sexual harassment into the public domain. Because our first bit was a feeling in the past, and this is the feedback we had from CQC in two broad domains. One was around our approach to dealing with colleagues with disability and making reasonable adjustments, and the other one was around sexual harassment. The bravery of people to come forward and to be able to speak up has been supported by giving that degree of anonymity, which is why we don't tend to go into that. But if we look at the EHRC definition into sexual harassment, and it talks about, sexual discrimination, talks about sexual harassment, and that's a big piece that's linked to workplace, and very, very timely, we mentioned at our board development session this afternoon, literally where I've come from on sexual harassment, and actually a stock take of where we are, and we look at the story that's unfolding in terms of cricket and almost the banter, the culture, the environment, and that's the change that we're looking at within there as well. And just to give a bit more of a flavour going into too much detail, sexual harassment does range from physical to verbal within there as well, so it is multifaceted within that. We do engage with police if required, and we do play with the safeguarding teams within the council as well. So it is multi-professional. We've increased our safeguarding, we've increased our freedom to speak up capacity, and all of that is part of being sustained and a sustainable organisation to deal going forward. And that's in addition to the cultural work that we've undertaken. And I think your last point, if again, please pick me up if I haven't answered the question, was around another pandemic. I really would not want another pandemic, and I probably would say we are still dealing with it. And I think we need to be really clear that on top of winter, we know, and working in partnership, and you've got colleagues from MWAFT here, working in that partnership of the system as a whole is under significant pressure. It is a pandemic that is still ongoing. We're not out the other side. We need people to take up their booster vaccines. You can see them. We need seasonal flu. So there are so many things in there as well. What do I think is a litmus test in that is it will be really difficult. Why will it be difficult? Because the main one of the best things about the NHS that I've got is our people, and our people are tired. And we have to recognise that working during the summer in level 3 PPE and beating down sunlight, and they've done that for days, weeks, hours, that is really, really difficult. And we are having to support them really heavily in terms of mental health well-being as well. So I hope I'm been able to answer your questions.
Yes, thank you. Very comprehensive. There were some points that I think, as a committee, it would be good if you come back to us on. Do we have any scheduled updates on this report to see if how they're progressing, or are they improving, or indeed are they getting better?
No, we don't, but obviously you can ask for one, yes.
I think if the committee permits, I would like an update on this report, just for progression, not to necessarily criticise anything, but just for show support for how you're improving things, and then ask questions on the way. Thank you.
Councillor Ball.
Thank you, Chair. If I could stick on, with page 15 and turning to paragraph 2.2, out of the 178 CQC actions, 13% relate to the lower confidence levels. Can you give us examples of the kinds of actions that seem longer and harder to turn around? I've noted the preparedness actions in paragraph 7 and 7.1 for this winter, but it would be really good to know what the 13% sticking points are and what remedies and resolutions you've got in train to combat them. Thank you.
Thank you. Yeah, some of them are what we class as the embed sustain elements within it, because we've not been able to demonstrate, or we feel we've been able to demonstrate some of the sustainability, and some of them are, if I use relatively simple, is clearing the backlog of job evaluations, it has taken us a while to find a sustainable route to be able to do those on a consistent. So the kind of, if I use the term, those which are the immediate burning platform, which I made reference to, they are the ones that we've focused on. What we've then had to learn through all of those is some of our longer term systems processes have required to be undertaken. If I look at a couple of the areas for me that I look after under the improvement plan, which is around our private ambulance service provision and subcontracting arrangements, this is in part how we've worded some of the actions, because our process means that we would visit our companies every 12 months, but the action is visit all of our companies and then close the action. But because it's continuous, it becomes very difficult, so we're having to learn within those as well. What I would offer, just for some reassurance within that, in terms of the monitoring of these are monitored very, very closely, as you can appreciate, and we do have very regular dialogue, both formally with the Care Quality Commission through our relationship meetings, and also I think one of the key bits that was underlying in here is a very open relationship, which is informal as well as formal, and it's important that we are very open, and the theme with our staff as well.
Thank you for that. I'm sure that job evaluation isn't the only thing outstanding in that 13%, but I would proffer that job evaluation is all part of job satisfaction, and that goes a long way to increasing morale. I do have another question on page 14, if Chair will permit me.
Okay.
It's paragraph 1.3 and 1.4. Having signed a contract with MediPro for apprentices and learners, can you say how many, if any, apprentices left the organisation before you were able to source an alternative education provider?
Right here, right now, no, because I've got the details of 48 staff left during the last month. What I couldn't tell you is whether they were apprentices or not. What I know from the figures that I've seen, we are in effect transferring over 600 learners to MediPro, which would say that the number out of that 48 is likely to be low, but I can confirm that at outside of the meeting.
That would be good, thank you.
Councillor Emraj.
Hi, my question's on 2.5. Since the changes of training providers, have there been any delays in those apprentices completing their paramedic training? And if so, how long has the delays been? And going back to my colleague, Councillor June Bowl, what are the levels of trainers dropping out of the training itself since the change over to MediPro? Thank you.
Thank you. So in terms of the delay at most would be a 12-week period. Although it's measured in learning time, learning hours and achievement. So there may have been a pause, doesn't necessarily mean it will have an impact, because it's still possible to carry on with work and have that progressed over. We will have a better understanding for each cohort of learning from the end of this month, because that's at this stage we've now commenced all of the individual meetings with the learners and the new provider to, in effect, you do an assessment of where an individual is, and then you can work out what they have left to do as well. So that's where we are, but we're anticipating worst case scenario, that 3-month delay at this moment in time. In terms of levers from that, so because we've just started the process, the actual answer is we haven't, to our knowledge, and I'd have to, we've not had anybody who's wanted to opt out who's not on the list, if that makes sense, and that could be slightly different to those who may have left. So I don't want to confuse the answer to say it's one or the other, but our plan is that it's over the 600 learners that we'll be taking forward on there, but I will confirm in terms of have we've had any left who've left because of it.
Councillor Burbidge.
Thank you, Chair. I'd like to echo the thanks as well for your services. I've had reason to call on you guys a few times in the last couple of months for my father, and it's been second to none every time. Which kind of leads me into my question, which I'd like to ask about the ambulance waiting times, if possible, particularly at A&E. In an ideal world, I'm guessing that an ambulance crew would take a call, go out, treat the patient. If needed to bring them back to A&E, they would do that, pass them over to the A&E staff to treat, clean down the vehicle, restock and go to the next one. However, in real terms, what's happening is they're getting back to A&E, and then they are sitting there for sometimes hours upon hours with the patient in the back of the vehicle. What, in your opinion, is the cause of that, and how would you solve it?
I would say thank you for the question, but I'm not. In terms of if I had the answer, I would love to share it in total. So you're absolutely right, and I wouldn't agree. You know, it is serious and it is significant within that. And I would start by thanking you for your comments about the staff. So the way I view hospital handover delays and challenges, they're a symptom of something. You know, nobody sets out to have delays. Nobody says that's the plan, and they tend to be symptomatic of a number of things. So some of that is about the ability for, and I know colleagues from NWAFT are here, but you know, in the discussions we would have, they are multifactorial again, which is the ability to flow patients to discharge, to be able to access other alternative services, and also complexity of patients. So the bit excuse me, the bit that we have seen, and part of the solution, this won't be absolutely everything, is one, recognising the patients and the risk across the whole system. So this is never about one part of health or social care, it has to be a whole system. The second bit is about identifying key actions and activities, which I've seen in the work that's going on with NWAFT, and we're part of that, which is about activities that will make a difference on those. So some of that will be about supporting discharge, and we do that through our patient transport service. The other bit would also be about supportive decision making for our ambulance crews and ambulance staff, to be able to say it doesn't have to be the emergency department where patients go to. Can we access and support them with same day emergency care? Can we access to advice through a consultant in complex frail elderly medicine? Can we make more use of working with 111? So there are a number of things that would say it can't be, you know, this isn't a case of more beds to answer the problem. It's not as simple as that, and it's very much tied into how we work together, systems working together, managing that risk, and indeed workforce. And so I think if I was to say where do I think we would focus on, and particularly in some of the conversations, yes, systems and processes can be reviewed and looked at, but I think very much here is about how as a collective we work with our workforce to, you know, support ambulance crews to make different decisions and assist them in that, whether it be from the mental health team, whether it be, as I said, from consultants. And that's just a different way of working, so we can try and work through that and offer those alternatives.
Councillor Farouk.
Thank you, Chair, and thank you for your report. I have a couple of questions, slightly unrelated, if I may ask them together. So the first one sort of follows up from Councillor Burbidge, in the sense, how many sort of private ambulance companies or services do we have available which we can sort of rely on if needs be? And secondly, do we have any sort of statistical breakdown over the amount of calls we receive which relate to a patient's physical well-being versus sort of mental health needs, and in the categories you've listed in terms of C1 to C4, how are these sort of mental health calls classed as, please? Thank you.
Thank you. So in terms of a private ambulance provision, it is a framework provision, so it means that companies apply to go on the framework subject to a range of checks. So we're currently working through signing off additional companies, which will, in broad principle, if they meet the standard, take us to around 20 companies that we are using. At this moment in time, we are using 12 regularly in various numbers, and they're what's known as core contract and ad hoc provision as well, so some have core provision in there. Obviously the ranges within that is some companies are small and provide 1 or 2 ambulances, some are slightly bigger and can provide double figures. I think it is fair just to say that we're not the only ambulance trust who are using private ambulance service, so the numbers on a day, these are not hundreds a day. We are between 20 and 35 a day across the whole region, depending on the numbers that we're able to get. I think in terms of the figures, so I can break that down. Off the top of my head, I don't have the exact figures, so I wouldn't want to to make that up. But if I just explain where some of the patients who phone with I guess mental unwellness in there, we know that they actually cover category 1, 2 and 3. And the reason I say that is because it depends on what the chief presenting complaint is. So if I use the example, if a patient was being detained by the police under section 136 and they have active restraint, that would trigger a category 1, and that's based around the learning, and we've seen it in the press of how at risk that could be, because both they are physically at risk as well as mentally unwell. We would find that if somebody were to have undertaken deliberate self-harm to cut themselves, depending on the nature and where that was of the injury, that could trigger category 2 because of its serious bleeding. So it would be almost the presenting symptom is the one that drives the triage category, because that's how triage works. And then for a number of others, they would be within our category 3, category 4 and category 5. Category 5, we don't often talk about category 5, but you'll hear us talk about hear and treat. And that's what category 5 is codes or patients who've been triaged that would be suitable for hear and treat.
Thank you.
Councillor Emraj.
Got 2 questions for you. You stated in your presentation about staff being exhausted, myself being an NHS worker. 7.1, you state increasing overtime levels for existing and experienced staff. What is the limit of how much overtime staff can work? And there will be a time when staff will actually turn down the overtime because they're exhausted. And what is your backup plan when we stop relying on staff to actually do that overtime? Because there will be a time when staff won't do it anymore. Thank you.
Yeah, thank you. So the ambulance service is, if I use it as a sector, we tend to produce around 10% of our, and forgive us, we work in hours because it's hours of ambulances on the road. So we tend to produce around 10% of our patient-facing staff hours through overtime, and that's generally as a sector. Ours ranges between around 9 to 13%. So it is a heavy use in terms of overtime, and has been there, and a number of those are generally derived actually from it's very difficult to set up a bank model because they're the same small pool of staff, and it's not as transferable because there isn't the amount of paramedics available, so they tend to be in there. We do, and I think I would say, we do recognise that as we progress into winter, we're having to put another range of options in. So you'll have seen during the year, we made use of the military and asked them for support. We're able to now, we've started additional recruitment for our non-emergency patient transport to then release staff to come and work on front line. We're also using overtime and incentivisation within overtime as well. And all of those are while we try to then look at that sustainable area, particularly around recruitment and development. So we've got through the pandemic, one of the challenges we had was around getting people the right category of driving licence, and that means we're clearing some backlog through our kind of training providers, and then into the elements with the apprenticeship. So it's about making staff who are with us workforce effective as well. So actually, are we maximising it? I think there's another dimension to your question which is really important, which is about well-being. So, that's what I've described is almost the numbers bit, but behind every number is a person. And we know the area that we've described around a culture is really important about how people feel at work. And so councillors' point around job evaluation, I completely agree in terms of how people feel valued. And it's also about the interventions that we're able to put in around our health and wellbeing plan to support and assist that as well. Not only have we got our occupational health contract, not only are we working with the health and wellbeing hubs within the region, we're also bringing in additional health and wellbeing practitioners to support as well. And I'm kind of challenging ourselves internally of can we go kind of harder and faster in that as well, and could we be brave and put a health and wellbeing practitioner at every hub station? We've got 19. Could we do it, even to try and see how we were? Because we also know that life is complex for people, and some of this will be work, some of it will be the pandemic, and some of it will be home, and therefore if we can make it I guess accessible, and the other bit I touched upon in terms of the CQC is also where we have staff with difficulties, is can we think about how we solve a problem, not thinking they are a problem, and that's a mindset element that's really important. Things of can we make reasonable adjustments? And I was speaking to some of my managers the other day and seeing really good examples of people not going sick because they're taking a different approach to don't go off sick, let's stand you down, let's replan, and that's positive as well. But I think our longer term bit in here is going to be about recruitment and staffing numbers.
Yeah.
Going back onto well-being, obviously taking annual leave is one of the biggest part, and by law we have to take a percentage of annual leave. So do you make sure that your colleagues are taking their annual leave and not working any overtime during that annual leave period? Thank you.
Thanks. And I realised I didn't answer one of your questions, which is about overtime and maximum amount of overtime. So people obviously can opt out of the working time directive, and we do monitor it. There is a kind of an upper threshold limit that we would flag on our reports, which is 100 hours in a month. That's high, and we do have some colleagues who do that as well. In terms of overtime during annual leave, so yes, we do monitor it. Do we have a kind of, if I use the term a ban? We don't have a ban, but we do monitor it. What we see at the moment is we see our abstractions for annual leave is about 18 to 20% of each week. So that gives me confidence that people are taking leave. Even with the impact of COVID, when we went into this financial year, it based the kind of the numbers or the hours of annual leave people had to take, it would increase our abstraction by 0.2%. So that would say to me, in terms of very numbers, and then speaking with colleagues, people were taking leave. So that is reassuring, and it is really important for resilience and also role modelling to make sure people, leaders, staff, everyone has time to recover and recuperate.
Councillor Ball.
Thank you, Chair. This is partly related to Councillor Farouk's question on private ambulance intervention. It's on page 19, and it's 4.3 paragraph 4.3. How long do your statisticians project you'll be operating at REAP 4 level? Thank you.
So we've been at REAP level 4 since July. I've been in the ambulance service 23 years, and we've hit odd days of REAP 4 at the peak of winter. So you can see where my answer is leading to in this is it is really difficult. Nationally, when I checked again this morning, every English ambulance trust is on REAP 4 still. So that is and our home nations are also on the same as well. So that just shows the significant level of pressure. Today, I think the discussion I've had, and we're having it with our board tomorrow, so we had exec today and board tomorrow. I am planning our activities against REAP 4 being in through winter into February into March. Now, if things change positively, that's great, because I can always de-escalate, but actually what we're looking at is how do we live in a very sustained and pressurised environment right through now to the end of the financial year to get through winter.
Just looking at the statistics, and I really appreciate your answer, and it's helpful. February, March is the projection time to next year. But matching that pressure, the Resource Escalation Action Plan, REAP 4, to the actual resources, has anyone done any projections on that, looking at your workflow capacity capability against REAP? Thank you.
Yes, they have, and I was on the phone on the way up to my head of performance and planning to do exactly that. So the things that would go in terms of the model within that is activity or patient need is one. How long it takes us to complete the care for a patient, and the other one is how many hours we can predict. And the reliable bit, coming back to the councillor's question of use of overtime, we plan as a baseline on our whole time equivalent staffing. So what we were talking about on the way is around our workforce planning, and that will be a wider discussion at exec team, but actually we're able to predict what we think and what we call our raw patient-facing staff hours will be when you take out annual leave, sickness, you will be able to work that. And so we can model that through for the rest of the financial year as well.
Mr. Chair, would it be possible for us to have sight of that statistical data? It's all part of evaluation and scrutiny.
Are you able to send that through? Yeah. If you could send it through for us then, please. Thank you. Could you just clarify for Paulina, Councillor Bull, what you would like?
It's the answer to which Mr. Bailey gave to my question about how long they expect their statisticians have projected that they'll be operating at the REAP4 level. And I understand it's the answer is around activity regarding patient need, the care, the hours, the overtime, the whole time equivalent, and they're doing some workforce planning. That's what I heard. Thank you.
Okay.
I think to say we have that in a visual graph, which would show what we think we can respond to.
I'm grateful. Thank you.
Thank you very much. Any more questions from members? Recommendation. It is recommended that the Adults and Health Scrutiny Committee note the contents of the East report to Peterborough City Council Adults and Health Scrutiny Committee attached up Appendix 1. Also, there was whether you want to call it a recommendation from Councillor Barkham that we have an update. I don't know what time would be appropriate for you to come back. It's an action, not a recommendation, an action. When will it be appropriate for you to come back?
Would it be possible to liaise, recognising winter and December and January, would it be possible to liaise outside with a date? So not to be months and months, but if that would be permissible.
Is that okay? Well, thank you very much for coming along. And just like has been said before, please pass on our thanks to all the ambulance staff that are the hard work they've put in for the last 20 months. Thank you very much. Agenda item 6, the North West Anglia NHS Foundation Trust COVID Recovery Plan for Elective Care and Winter Pressures. I think there's some wipes on there if you'd like to wipe the microphone if you want to. Well, no, I think nobody's used yours, but you can do if you want to, yeah. You better show, William, being you're in the... yeah. Right, over to you then, Phil. Could you just put your mic on, please? And just move it a bit close so we can hear you. Thank you.
Can you hear me now?
Yeah, it's lovely.
Fantastic. Thank you and good evening. What I intend to do, if it's okay with yourself, Chair, is just talk to the cover page. There is a presentation, which I'm assuming people have read, and then we will be able to take questions after that. So as you'll see from the cover page, this is essentially a report, and what you've got is a presentation attached to this, which is a summary of a 60-page document of significantly wider, obviously, that covers the whole of our plan. This is essentially a breakdown that puts it in terms of context, why we are where we think we are and what our plans are for winter. I think it is important to note that two things. One, that this is a live plan and it will change as things go forward because of the nature of both the impact on the hospital around ill health, COVID, RSV and flu are particular concerns for us, but also because of interdependencies across the patient pathway. This is not just a plan on its own, it's part of a system-wide plan. So the background and the key issues. We've had an external company who've been in and have understood our current activity and predicted forward that if we continue with our current way of working, we will be in deficit to the tune of some 70 to 90 beds. That is quite a considerable pressure, and we're actually seeing that at the moment. So we have a substantial number of patients who are being cared for in our emergency department overnight, which is inappropriate, and actually I almost answered Marcus's ask earlier on about issues around exit from ED, and I'm happy to go back to that question if you want to repeat. I get the sense that you will want to repeat that question. We are going to have a difficult winter. I think it would be foolish of me to sit here and say that we won't. There's a number of key issues around that. We've seen a very long and prolonged pandemic, which has exhausted our staff. We have a cohort of staff who are now very tired. They have worked tirelessly, and they have worked with real commitment and real passion. But there is a point at which they are starting to run out of energy, and I think we saw this really kicking in 2 or 3 months ago. We are struggling to recruit staff. That's not just us, the NHS, but not just the NHS, the healthcare sector per se, and yourselves as well, I'm aware, are struggling to recruit staff, and that's impacting right the way across the whole patient pathway. We are seeing that impact in terms of both what we're able to do, but in terms of what other people, other organisations are able to do to support us. And we'll come on to issues around discharge later on. And we're also expecting to see a surge in respiratory infections. The masks that we've all been wearing have been absolutely fantastic, but one of the things that is evident is that people have not built up their normal resistance to things like respiratory syncytial virus, which affects children, or the flu. And whereas before they would have been passing round, we have a Director of Public Health here, so I will speak advisedly, but whereas we would normally build up some level of resistance, we're likely to see less of that in the population. So this year we are expecting and have planned for increases in flu and RSV infections in children, as well as a potential further surge in COVID. But that again puts more pressure on us as an organisation. So what are we doing? We're really focusing on the well-being of our staff. The staff that we've got at the moment are tired, as we've said. They are exhausted, both from their professional but also from their personal lives. They put up with, as we all have, a long period of pressure. So we're putting a lot of effort into supporting staff, both in terms of the psychological support, but also other things that we can do to help their well-being. And we've put quite a lot of money into the system. We ourselves as an organisation have committed £3.5 million to support both the emergency and the elective workload over winter, and I can describe that in more detail if required. And the system, the ICS, have put in a further £12 million. Now, 7 of that was to extend activities that had already been running across the year, some of which you're kindly providing. But there's a further £4 million, 2 of which has come to NWAFT, and that's being used specifically to extend the ITU capacity at PCH, as well as keeping a further 19 beds open across winter. I think it is worth noting that the key performance indicators that are in here talk about ambulance handovers and delays. It is one of the national indicators, and we've been told from NHS England that we are not to have ambulance delays. They've described it as not using ambulances as cubicles, and we are working with the ambulance service and with NHS England about how we can improve our performance, and also reducing patient time in ED. We know that a length of time longer than 8 hours is associated with increased morbidity and mortality of patients in ED. So there is now a national target of a maximum of 12 hours in the A&E department. At the same time, and this is very different to last year we'd been allowed to stand down all elective activity, and by that I mean surgical activity as well as outpatients. This year we have been told that we have to maintain our surgical activity and in fact increase some of our surgical activity. So there is a bigger pressure coming in from the elective work. In last year, in the middle of COVID, we were able to stand that down, which gave us an increased opportunity to move staff around. We not only don't have that opportunity this year, but actually there's a further increased demand on those staff. So, as I've said, we will be spending about £1.5 million on additional emergency capacity this year. That's particularly around the same-day emergency care, and transferring about 10 beds worth of activity from elective activity from Peterborough City Hospital to Hinchingbrooke. And as well as that, we will be looking at a further £2 million of trying to maintain our elective activity across winter, so that what we don't do is build up a long waiting list that we then have to try and address in spring. I will stop there if that's okay, and then I'm happy to take any questions.
Just before you go on, could you, for a non-medical person, RSV?
So it's, and I hate this.
I take it's a respiratory, is it?
It's a respiratory syncytial virus. It particularly affects children. And as an ex-paediatric nurse, it is something that you really don't want to see, particularly in the very younger child. So what we have seen is quite an increased demand on our paediatric wards, on our paediatric HDUs, and on our paediatric intensive cares within the system. We obviously don't have a paediatric intensive care, but we are seeing quite a lot of pressure in the A&E department around young children. That's part of the increase in activity that we have seen.
And further in the report, reduction in LOS.
Length of stay. I do apologise. Yes. With the NHS is, as you are only too well aware, I'm sure, very prone to its acronyms. It does love a good acronym. So please, if there's anything in there that doesn't make sense, do ask and we'll correct.
Thank you. Lovely. Thank you. Councillor Kayam.
Thank you, Chair. And again, I'll start off by thanking you on behalf of all my colleagues here for the tremendous efforts that you and your staff are putting in since the beginning of the pandemic and all the time, really. I was really interested in the aspect, being a GP, that in your plan overview, point number 1, which specifically states reasons to reside criteria. Now, over the course of the last couple of weeks, when we have seen an increase in patients being discharged, a number of those that I've been exposed to have been failed discharges. Do we have any data on how many of those patients are readmitted from failed discharges? That's the first question. The second question is, what are your reasons to reside? Thank you.
So, excuse me, on the failed discharges, they're normally around the complex patients, and of those we do about 30 a day, 25 to 30 a day. There's actually a very small percentage, it's around 1 to 2% of those are failed discharges, and most of those are about either us failing to prepare early enough in the patient's discharge, and that's part of what we're doing to try and improve our processes across winter, particularly around things like discharge drugs. But it's equally that we often don't coordinate well with our community colleagues, so that when the patient gets home, the level of care that's required at home is greater, or the ability of that patient to cope at home is not as good as we had thought. So we do see a number of the patients coming back in. It's probably about 10 to 20% of those patients actually come back. A lot of the time we can manage those patients at home, but it does require a lot of extra resource.
Can I come back on that, please? Thank you, Chair. Thank you very much. It was a helpful response. My concern is that we always see this hiatus every year, and it seems to get worse year on year. More so this year is anticipated because we have increasing numbers of COVID infection. Do we have an actual intermediate care team in place? Because I often see quite a lack of that rehabilitation that is so essentially needed for patients going into the community. So when you refer to community partners, are we talking about the district nurses, or is there a rehabilitation intermediate care team?
So there's a very good rehabilitation intermediate care team, and we're looking to try and enhance it across this winter so that we've got greater capacity. A big part of our winter plan is to try and buy an additional set of what would be residential care homes, but almost that kind of step down interregnum between an acute environment and taking the patient home. So I would say we've got a very strong offer here. Our biggest problem at the moment is actually getting staff. So it's not just the health service, but the local authority, private providers, all of whom are struggling to find staff. So that's one of my bigger concerns, is not just our inability to recruit, but the whole patient pathway, the people who support that patient across the pathway struggling to recruit. And that does actually start with primary care all the way through to domestic support to keep people at home.
Thank you. I think that's been useful. Have there been problems identified as to why there is a difficulty to recruit staff? We know what it is in primary care. I'm just conscious of this vicious circle developing. The pressure on primary care invariably leads to an increased number of people presenting to A&E. So have we identified, is there anything that we can do to help you?
So I think we know that there are issues in obtaining professional staff, particularly registered nurses, registered doctors, registered social workers. We know that for us in the NHS there's probably been a reduction, well there has been a reduction in the Health Education England budget for the last 10 years, and I think we're seeing a consequence of that in terms of not having UK trained doctors and nurses available. We had been quite reliant on doctors and nurses coming through from the international market, particularly from Europe. And again, that supply has been cut off. And then just to make things worse, of course, with COVID, there's been a very strong moratorium on international travel. So even our ability to recruit on the international scale has also been reduced. So I think it's a kind of triple whammy. We are not training our own, we're not able to get doctors and nurses from Europe in the way that we used to be able to, and we're not able to tap into an international market. Where I'm slightly more surprised is our inability to recruit healthcare assistants, which we struggle with. And that one we are doing as much work as we possibly can on, because I think if we can support other partners, but we are struggling to get hold of healthcare assistants, and that's the first time in 40 years in the NHS that I've seen that happen.
That's incredibly interesting. Thank you very much. Thank you.
Councillor Ball.
Thank you, Chair. If I could turn to pages 23, paragraph 2.4 and page 24, paragraph 3. I appreciate that the plan is fluid, but has much changed since the sign-off at the end of last month regarding resilience improvement, bed modelling and occupancy levels? We've heard you've got a 70-bed deficit, the planning assumptions used and the winter schemes. And I encompass that question on the basis that I fully appreciate we're moving from pandemic to endemic. So presumably some fluidity has to be within the plan, but some solid modelling. I mean, you've articulated what you think is the worst thing that's happened in 40 years, and presumably that's being modelled in by your statisticians to get some semblance of order.
Yes, so this is the most likely scenario. We also had a best and a worst case scenario. What we're seeing is Peterborough has one of the, well, you know as well as I do, it has one of the highest population rates of COVID. We are the second highest rate of hospital admissions in the east of England, and the east of England is the second highest or the second worst in terms of the number of patients being admitted. So we have modelled it to 60 beds. We're currently sitting at 83 patients in the organisation. Now, to put that in context, we are seeing a different group of patients this time round. So previously patients were being admitted with COVID. What we're now seeing is that vaccinations are bringing people in with undiagnosed COVID, and it's because we're testing them as they're coming through the door that we find that they've got COVID. And that's about half of the patients that we're seeing. That doesn't stop the fact that we then have to manage them differently and produce a different ward. So it still leaves us with a pressure but the patients aren't as sick. So at the moment, we are running at around, it would depend, but Hinchinbrook Hospital runs at about 92 to 93% bed occupancy. Peterborough runs between 98 and 101% bed occupancy, depending on whether we've opened up beds that aren't properly staffed, as in they're not budgeted, they're obviously safely staffed. So we are seeing at the moment a surge. It is coming down. 2 weeks ago, we had 105 patients in the hospital. So as of this morning, we've got 83. So we are seeing a gradual coming down. It's worth noting that the expectation is 2 weeks after the peak, we will see a peak in intensive care admissions. So we're now getting ready for surge, what we call surge 2 levels of intensive care. So we won't just be full on our ITU beds, but we've got additional ITU capacity that we can move into and is available to be staffed if we need it. We're not seeing that. We're not having to use it at the moment, but we're prepared for it.
I represent the parishes for Peterborough, and several of the residents have come and told me personal stories about the trouble they've had where someone's attended as an A&E patient and then been held in the 48-hour bed scenario, which has sometimes ended up as being 5 or 6 days or sometimes 2 to 3 weeks. But they say the underlying cause of all of that happening is because there are pressures on beds in the gastro wards. Is that something that you could comment on?
So, to be fair, there are pressures on all of the wards. There is one gastro ward. There are often patients waiting to get in there. We are working to get the systems aligned properly so that we can identify the right patient for the right bed as soon as is possible. And as part of our longer-term plans, we will realign the beds with the demand that patients are offering. But your point about, excuse me, I'm about 5 days beyond a cold, so my throat's going, but I'm perfectly clear. And I've done my LFT this morning, you'll be pleased to know, so that's also clear. But what we are seeing is that there are a number of patients, and you described it very well, who only want a short period of care but get caught up in a system that brings them in for 48 hours and then 5 days and then 2 weeks. What we are doing as part of our winter plan is investing around, off the top of my head, I think it's about £480,000 to £500,000 in increasing our ability to manage patients right at the front door, see them quickly with the appropriate skill set, and then discharge them home. So we're really keen on what's known as SDEC, same-day emergency care, to avoid bringing patients into hospital. Hospitals are really great places if you are, I always describe it, 1 week either side of an intensive care bed or a theatre. Outside of that, they're the wrong place for a patient to be, and we're very keen to not keep patients there.
Thank you for that very helpful and comprehensive response. Much appreciated.
Councillor Burbidge.
Once again, echo my thanks. As I mentioned earlier with my father, obviously after coming off the ambulance, the next person he saw was in A&E, and I thank you for everything that went there. So the obvious question, I'll ask you the same. What do you see as the cause for the bottlenecks at A&E that are keeping patients on the backs of ambulances for hours at a time? And how would you see that that could be fixed? The second one is, obviously we've had the move now from the City Care Centre of the UTC. How do you see that bedding in? How do you think it's running? And do you think that's had any impact, positive or negative, on the on A&E? And the third question, if I can, is obviously as we're coming out of the pandemic, what we're finding is that a lot of the routine surgical procedures have been left wanting. So how do we see moving forward to catch up with the operations and the treatments that have been left behind?
Okay, so with regards ED, I'm probably slightly less ambiguous than Marcus. There is a lot of evidence around why EDs get blocked up, and that's about the bed occupancy in a hospital. So you will see that we describe our intended bed occupancy at around 92%, between 92 and 94% gives you a 6% variation to allow for peaks and troughs in activity. If you don't get that, you get a thing from ED called exit block. Exit block is where patients are unable to move straight out of the A&E department into a bed when they require an inpatient bed. And what you then get is patients queuing to get into the cubicles that those patients are sitting in, or you're having to move people out of the cubicles so that you can bring somebody in. There is a very clear correlation. There's any number of studies that show that link, and I think what we need to do, and it's not just MWAFT, but it is a big part of MWAFT's job, is to improve our processes so that we don't have 48 hours and 5 days and 3 weeks, that we do start planning from the moment that they come through the door to their discharge plan, particularly around the more complex, the more frail patients, and that we work with our partner organisations to make sure that there is as much capacity to discharge patients as soon as they are medically fit. So at the moment, as of this morning, we had 125 medically fit for discharge patients. Their average length of stay from their point of being declared medically fit for discharge to being discharged is 5.8 days. So that essentially is about 600 bed days lost. If we recovered that capacity, or we got it to a reasonable place, we would then be looking at a 95% bed occupancy. That would allow us to start moving patients out of ED and move patients off the ambulances that much quicker. So that's the simple answer. The complex answer is actually enacting it, getting better discharges. We're putting resources into increasing the internal discharge capacity, and we are working with yourselves, in fact, about trying to increase our opportunities to discharge into the residential home market. So if we can do that and make better use of what's available, we would expect to bring the occupancy down and then improve the flow out of ED. With regards to the urgent treatment centre, yes, it's been brilliant. And I think it's safe to say, if you look at what we are now doing, 37% of the people coming to the front door of our A&E now get seen in the urgent treatment centre, around 138 patients a day. And that is performing at a very high level, so it's at above 90% of patients seen and discharged within 4 hours. So it's an excellent service, it's an excellent offer, and we've had a number of visits from around the country for people coming to see how we've done it and why it's working so well. So I think without that, we would be in a significantly worse place. With regards to recovering the elective activity, you'll see from the presentation, there's about £2 million that we have set aside as an organisation to try and recover our activity. I think it's fair to say we initially thought we would be able to talk to our own staff about offering them enhancements and asking them to support us to get more elective work done. They're just too tired, if I'm honest. They're just not interested in doing the work, which again is the first time I've ever seen that happen. So we're now working with a number of external companies to get them to bring their staff into our buildings and use our resources when we're not using them. And that should actually improve our elective waiting position. So by March, end of March 2022, we are intending to not have anybody waiting longer than 2 years, and to have brought down our over 1 year waiting list, and to have held our waiting list stable at the September rates from this year. So we're doing a lot of work to try and improve that very long wait, because those are the patients that worry me. We prioritise all of our patients, so P1 and P2 are seen quickly, sorted, brought in and treated. Cancer patients are exactly the same. We do those patients very quickly. It is the patient who's waited for 2 years with poor eyesight or in long-term chronic pain that worries me, because they could potentially never get treated. So nationally they've set a cap on a 2 year waiting list, and we will do everything we can to deliver on that.
Councillor Barkham.
Hi. Briefly, on the winter plan. So it's really regards to communication from you, the NHS as organisation. You're making plans for expectations for high levels of demand for the services. So is that communicated with any other organisations with regards to their preventative work that can tackle the assumptions that you're expecting, for example? You can come back to me. I've got some plans that I want to cover. Unless you want to come back on each one, what would you prefer?
I will come back on each one if that's
Sure.
all right, just because I have a shocking memory. So, if
there's not that many.
Okay. So the simple answer is yes. We're working with a number of organisations, both local authority, our community partners. We're working with primary care. We're doing a lot of work with the voluntary sector as well at the moment to try and encourage people to manage their own care and do self-care at home.
Okay, because I've asked the question in other meetings with regards to preventative work, and there's very limited amounts of it being done, really. That's why I want to ask the question, so at least you're aware, because it could help, I suspect.
Absolutely, and I think the biggest thing that we can do and are trying to do this year is to encourage vaccinations, both the double jab but also the flu, because I think people are forgetting that the flu is just as likely to cause you to be in hospital. It won't have quite as big an impact as COVID, but we are really pushing both of those, both from our staff but from a public campaign as well.
Okay, thank you for mentioning that. I was going to come on to the vaccine. You commented on difficulties of recruitment. So the care sector, there's been the enforcement of the requirement to have the vaccination. That has left people either deciding, do I have a job or do I leave the industry? The NHS, I believe, are expanding that with regards to the majority of employees with a requirement to have the vaccination. If they don't want it, they have to leave. Is that affecting recruitment? And is it enough that you may reconsider that option, for example?
So we heard this morning that the government have mandated that by the end of March, everybody working in the NHS will either be double vaccinated or will have to have a very strong reason as to why not. We've actually got quite a large percentage of our staff already double vaccinated, and we're very well aware of those who can't because of medical reasons. It actually leaves us with quite a small, a couple of hundred people who we would need to work through and understand. I do worry that it's not helpful in terms of recruitment. There are people who have fundamental objections to vaccinations of any sort, flu, COVID, whatever. So it won't be particularly helpful. I'll be honest, I struggle with it. As an ex-clinician, you had to have a number of vaccinations before you could go onto the ward. So I completely understand the push towards protecting patients that you're caring for. But yes, I suspect that it will cause us a small issue. We have got long enough to prepare for it, so I would expect by the time that turns up as a sort of end of March issue, we will have put plans in place to either manage those people to get their second vaccination or to have recruited into those posts.
Okay, thank you. Good time as lights go out.
Yes, absolutely.
Just finally, it was regards to the scheme summary, and it was probably some briefing comments, but they're quite ambiguous with the text that's been put there. So if we could elaborate somewhat, where we will need to focus on reducing the inpatient lengths of stay. You touched on that a little bit earlier, but the other one is we expect to see ongoing challenges across all staffing groups. Can you just elaborate on that, please?
So, as I said earlier on, we are struggling to recruit. So there are particular areas that we're struggling to recruit. The four that are a particular concern for me are the emergency pathway, so A&E and emergency medicine, maternity, paediatrics and intensive care. But there are also certain specialist groups, so speech and language therapists we're struggling with. We've got a particular issue with junior doctors because of the way the college rotations work. Across the board, there are either areas where we are struggling to recruit into or certain professional groups, all of which, so as part of our winter plan, we've actually allocated some money to increasing our recruitment team so that they can work on trying to fill those particular gaps.
So that's just relating to recruitment. You haven't mentioned any other ongoing issues?
So that is one of our ongoing issues are around all of those areas. I've been
okay, just recruitment.
Yeah.
Fine. Thank you.
Thank you. And the last question on this item is Councillor Farouk.
Thank you, Chair. I have three separate unrelated questions, if I may. and as you prefer, if we do them one by one.
Thank you.
If that's so the first one is relating to item 3.3, where you state we will be increasing our well-being offer to staff. Could you just outline sort of the measures for this?
So what we are doing, we're recruiting additional psychologists. So we've currently got psychologists working up on ITU. We're getting some more too. We're looking to recruit 2 more psychologists to support A&E. It's particularly difficult down there at the moment. We've got a winter event that we're currently planning, as well as a Christmas event. We have got an internet offer, as well as occupational health support that allows people to go straight into counselling. So there are a number of different routes, but the particular ones that we're focused on at the moment are the psychologists and enhancing our wellbeing offer on the internet to allow people to access occupational health, and through that a number of counselling services.
Thank you. Next question relates to sort of patient flow and reducing the impact on the emergency department. I know quite a few trusts sort of have a medical and surgical same-day emergency care to sort of facilitate that. Do we have, or has there ever been a situation in the last sort of 18 months or 18 or 20 months where that's not been enough capacity to sort of support the amount of patients that are, you know, turning up to A&E? And are there any sort of plans for if the capacity was to ever sort of go over what there is in medical and surgical same-day care?
So, to put it in context, we have an acute care unit which does same-day care. We have an acute medical unit. We have an acute gynae unit. We have a paediatric assessment unit and a surgical assessment unit. Those last 2 have only opened in the last 2 and 3 months. So we're starting to see the impact of those. We are working very hard on actually expanding what we offer at the front door to avoid people coming into A&E and going directly into an appropriate environment. The reality is that because of the pressures in the beds, we sometimes end up using those same day, the assessment units, for overnight capacity, which slows them down first thing in the morning. So it's not that we need more assessment capacity, we need more bedded capacity so that we don't obstruct the use of those beds first thing in the morning.
Thank you. And the last one's quite brief. It's just sort of relating to if we have any statistics based on the amount of people presenting at A&E who are not necessarily refused admittance but redirected elsewhere, or who are classed as not needing to be admitted into A&E.
So I can tell you literally day by day how many patients we have triaged at the front door and referred straight out of the door to another appropriate healthcare. It roughly sits, if I remember rightly, at about 3% of the patients we're seeing. So there's some 15 patients a day who we are advising to go to pharmacists, back to 111, back to somewhere else, who should not be coming to A&E. That's really kicked in since we've had the urgent treatment centre, and again that's one of the things that we are being watched very carefully on, because no other A&E, and I've worked in about 10 A&Es now, no other A&E I have ever seen has been able to do that. We all know that we should, but nobody has ever been able to do that, and that's thanks to some very skilled practitioners at the front door.
Sorry, just one follow-up, if I may. And in terms of sort of the follow-up, to follow from that, the patients who are admitted into A&E, and for example, if they need sort of haematological care, however the haematology ward is at full capacity already, what sort of provisions are there for that? Are those patients then sort of kept in sort of holding wards, or are they sort of kept in A&E until spaces become available?
It will depend on how unwell they are. If they're acutely unwell, we will get them to a haematology ward, but that will mean that we have to move a patient on that ward somewhere else. If we can't get them into that ward immediately and they're not an urgent, highly urgent case, we will manage them in A&E until a bed becomes available. But that means that it may not be a haematology bed, it means that it will be the next bed available, and then when a haematology bed comes up, they will be moved into that. It's not great, we would much rather admit people directly into the right ward, but A&E is the wrong place for people to be. So we'd like to get them into a bed first and then move them onto the right ward as soon as that bed becomes available.
Perfect. Thank you very much for that.
Thank you very much, members. I think it must be put out there that if you are offered the vaccination, you should go and get it. I had my booster on Saturday. I had my flu jab the Saturday before, so hopefully I'm covered. And if anybody's out there thinking about it, there's nothing to think about. You just go and have your jabs. And hopefully this epidemic or pandemic, whatever it is, will soon come to an end. Thank you very much. It is recommended that the Adults and Health Scrutiny Committee note the approach North West Anglia NHS Foundation Trust will take to prepare for Windsor to support the emergency and elective activity. Members agree with that? Okay. Lovely. Thank you.
Chair, could I be really cheeky and just thank particularly Charlotte and Will for the support they offer to the hospital day in, day out. I think it is just worth saying while I've got that opportunity, they have been absolutely brilliant.
I'd just like to say the support that the hospital, all the staff in the hospital give, and of course we must not forget GPs who do the work as well to make us all keep safe. Thank you. Thank you, Phil.
Thank you.
Right, agenda item 7, the relationship between the council and private sector commercial providers, adult social care. We have Will Patton, Oliver Hayward, this is going to be good, Carol Pogita, and I don't know whether Charlotte is, are you staying here or are you going up? You're staying here. Thank you very much, Sen. Whoever's leading off.
Thank you. And good evening, and thank you very much for giving us the opportunity to come and present this report. We're here to give an update to the committee on the council's commissioning relationship with our providers. Oliver Hayward, who's the Assistant Director for Commissioning, is here to help support that, and also to make sure that we give a balanced view. Carol has very kindly agreed to join us. And just a bit of background, Carol is the owner and director of Trust Care and also Focus Care Supported Living, which are very well respected providers in the city, as well as the director of the National Care Association and founder and member of the Peterborough and Cambridgeshire Care Association, so our local Care Association in Peterborough. I'd like to thank you for coming along. Moving on to the report, we'll give a brief overview and then move to questions, because I'm sure I'm hoping there'll be a lot of them. You'll note in the introduction that our providers play a critical role in ensuring that we meet our statutory duties, which includes working in collaboration, actually, and that's been an area that we have been focusing on. And collaboration in the sense of delivering the right services at the right place, at the right time, and of good quality, and in a sustainable way to meet the needs meet the needs of people who need those services. In 4.2, we give an overview of the numbers of providers and the range of services that they deliver. I suppose a key point to make here is that most of our providers are small to medium enterprises. They do offer a very wide range of services and looking after our most vulnerable people in Peterborough. they're also a very important part of our economy, particularly around things such as local employment and developing local skills. In 4.3, we describe what we call our touch points with our providers, and the pandemic has certainly influenced our relationship with providers and some of those touch points. So at a commissioning level, it's about how we work with our providers to review the way services are currently commissioned and where there might be opportunities to improve outcomes for people. We have contract managers who work with providers and support them so that they can maintain and deliver good quality services. We also have brokerage team who talk to our providers every single day, and they are largely placing individual packages with providers, and actually that team is a key link between what we've just heard in terms of discharging people from hospital into care packages. And then finally we have the social work operational teams who work in partnership with our providers and really focus on supporting the home at many different levels actually, and in addition supporting homes in terms of getting the best outcomes for the people that are being cared for. Under section 4.3.2 to 4.3.8, we've given some examples of the type of interactions that we have with providers. And then under 4.3.9, some feedback about the way that we work, and I'm sure Carol will give some more insight into that. Looking forward, we have some very significant challenges to come, and our view is that it's really important that we face those challenges in a way that we continue to work with and jointly address those challenges with our providers, and some examples of those are given. And then finally, under 4.5.9, there are other challenges coming down the path. Not least is the adult social care reform, which was announced in September. More detail is to follow around the implications of those reforms. We've outlined the current position as we've understood it in the report, but again, we believe there will be very significant implications for us and our providers, and we've already actually started to engage with the care associations because we need to work together to get the best possible results for the people that we care for. So if I stop there, if I may, Chair, and take some questions.
Carol, would you like to say anything?
Yes, I suppose I've got to get my mic close to the speaker. Good evening, everybody, and thank you very much for allowing me the opportunity to be here this evening, and thank you, Will, for inviting me. Yes, I need to thank the local authority on behalf of providers. And I want to say why. I'm going to elaborate on the interaction that we have had. Of course, there are always challenges that we are faced with as providers and local authorities. We are aware of those, and I'm sure that there will be questions from yourselves in relation to those challenges going forward. But I do want to say that in this local authority, and I sit on the National Care Association board, and whilst we were going through the major challenges that we have been going through with COVID, none of my colleagues were able to talk or speak positively about their local authorities. I was the only member within our board that was able to, and I really had to fight for my voice to be heard in connection with the way in which our local authority in Peterborough works. And just to put you in the picture, I do work nationally because our company provides services elsewhere in the country. So I work nationally. And I will say that in Peterborough, it was an exemplary experience. And I want to say why. Normally, people sit in their little glass houses and don't speak to providers because they are so important within their positions as officials. In this council, we received personal telephone calls. Our registered managers received telephone calls from the directors within this local authority. We had access, and I'm going to mention names without wanting to embarrass people, but I do think that it is time that we did give those people who actually acted as they should have acted towards the most vulnerable within society. And they may have fallen under the auspices of the local authority, but their humanity came through in every which way possible within this local authority, Peterborough. Wendy Ogle-Wellborn phoned every one of my managers and myself when we were at the height of our challenge. We were the first company, unfortunately, to be hit with COVID. That was prior to the testing of patients within the hospitals and discharge. So our home was hit very hard. We had lost in a very small home more than half, 3/4 of the client group. The local authority were there to meet our needs and the challenges that we faced. It happened on a Sunday night when I was able to phone Will at 9 o'clock at night. His team, Oliver Haywood, and Lisa Murray from the CCG, all of these people collaborated and worked with us in every way possible to make sure that we were supported. Our PPE had not come through. As you will know, that in the beginning, the PPE had been diverted to hospitals and we were not being able to have access to purchase sufficient or receive sufficient. We were supported by this local authority with additional PPE. There were no questions asked. There was nothing about money. I never heard one question about money. They acted, and subsequent to acting, we then sat down and collaborated further, as we should. And that tells me that the ethos, the culture, the ethics within this local authority is exemplary. And it is an example that should be advertised and learned about elsewhere in the country. Not only did we get telephone calls, we had 2 weekly meetings. Initially, they were weekly meetings. The providers then asked if those could be shifted to 2 weekly because of our resources and our availability in terms of time and being able to get to meetings. At these meetings, Mr. Haywood attended all of those meetings, and if the providers asked for any other expertise to be available, it was arranged and managed in an appropriate manner. I will say, and I say this reluctantly, but I think that in learning, we have got to be honest with ourselves, us as providers as well as any of the organisations that we work with in delivering the care that we do. PHE were really very poor in terms of their responses. However, unfortunately, again, the local authority listened to us. The quality compliance teams within the local authority then started acting as gatekeepers between ourselves as providers and PHE. That improved the relationship significantly, and initially when we did have the problems, because of people listening to what we had to say as providers and needing that support in our way, not in somebody else's way, we received that support and it was then sorted. It was a problem and a challenge that was then sorted. Testing, for example, in terms of our client groups when testing came about, we were a provider that it's been shouting from the treetops saying, please don't have static services, have mobile services, because these in care homes are necessary. They would work far quicker. We would get our staff and our client groups, we would have them tested very faster, sooner. Once again, Will and his team listened to what we had requested, and the first testing that was done at our care home, which was the first care home to go down with the COVID issues, we had a mobile unit come in. In one day, all of our clients were tested and all of our staff, which was really an exemplary manner in which to react to a call for help and a need. It's just a pity that further up the chain of command, outside obviously of the local authorities' remit, we were not listened to. But I need to place the good work squarely at Will and his team's feet. Staff cover, we were informed about staff cover, about voluntary services if the need arose, and we could phone and we could speak and make our needs known to this team. Providers had access to Will and his team, Oliver, at any time. And when I say at any time, as I said, my telephone call was at 9 o'clock at night because I was not getting a response outside of this area. So again, I need to say thank you. We also continued with the registered managers meetings, which were arranged by Sheila Scott and the late Janet Goodwin. They used to do those meetings on a regular basis, and those continued throughout COVID. Although they were Zoom meetings, we still had access, and it was very, very important that we had that networking. It helped with the education, it helped with training, it helped with sharing good practice. So it was a vitally important aspect that was covered at that time. The quality improvement team, as I had said, they assisted not only by being the gatekeepers between the providers and with Public Health England. And when I say gatekeepers in terms of assisting to get us access and quickly get us information that was required for our services at the time. They also helped the providers with infection control measures, teaching, training them. This is also done by Zoom, donning and doffing, COVID, the intricate detail in some of our care homes. As you know, these are not medically trained people. They don't have nursing or medical backgrounds. So it was really important that there was additional training that was being given to people to understand what COVID actually was. And these quality teams were assisting in this manner. They assisted providers as well with reviewing their risk assessments, making sure that they were compliant in accordance with the regulator, which was also vitally important because throughout COVID, it didn't mean to say that we could renege on our responsibility with our regulators. The auditing tools that we, for example, in some of our services where we had differences in terms of what the auditing tool should look like, these quality auditing teams listened to us and reviewed and revised and continue to do so. So they don't have an attitude of we know it all. They actually do collaborate. They do work with the providers. As far as training is concerned, we cannot fault our local authority. We can't fault our GP practices in terms of them assisting and helping throughout the COVID period. Yes, there is some reluctance in areas that, as a nurse, as an old nurse of 51 years, and having run hospitals and worked extensively in my profession, I know that there are things that we could do better. And listening to our colleague from health previously, there are things, of course, that we would like to do better, but those are for another day. Today, it's about the local authority and their ability to have assisted us with the most vulnerable within society, and I need to thank them.
Thank you very much, Carol. I'm sure our colleagues in adult social health Appreciate your kind words. Thank you. Councillor Ball?
Thank you, Chair, and I'd like to echo that. I mean, clearly, Carol, the glowing accolade you give in respect of the relations between this council and the private sector commercial providers is second to none, and that sits squarely with the director and her team, and also with some elected members that have been at the forefront of that. So I really echo the comments of our chair. But I would just like to turn to page 50, paragraph 4.514, if I may. I'm not sure who would answer this question, but my question is simply, what concerns do you have over the government's plans to ensure those who self-fund social care can ask the council to arrange it for them in order to access better rates? And will this reform potentially destabilise the care market even more than the challenges that are expressed on page 47? Thank you.
Do you mind? Yeah, your mic. So, in referencing the social care reforms, so I'll certainly give my view, and I'm sure Carol will give her view. So, in terms of the announcement, there's not a huge amount of detail in it. What we do know is that we'll be asked to arrange, and we assume assess, the self-funders, people who pay for their own care. Mm-hmm. And there are some key differences. One of the key differences is that those care costs, there'll be a cap of up to 86,000, but that's just for the care costs, not the accommodation costs. Correct. So, which we would call the hotel costs, crudely. So, and so in answer to your question, it's really unclear at the moment. For example, what happens if somebody doesn't come for an assessment and just places themselves into a care home through direct agreement to apply the care cap? Do they have to have an assessment? And if they do, and we place do we place at a local authority rate for the care, or a different rate, or is there a merging of the two? Or will there be some sort of care calculator that's agreed either locally or nationally? We're unsure at this stage. And then sort of the last point is around the accommodation and how that gets charged for, again, is really unclear. So from our perspective, as we stand today, it's really difficult to know, how things are going to pan out, both for our providers, but also for, the people that we support that will now include or will include self-funders. And I suppose we are, as guidance is released and information comes out, we will then work with other people in the local authority and, of course, providers and, of course, the community to try and understand the implications and work through those. Some of the implications we do expect will be very significant.
May I just push you on whether you think that particular arm of reform will destabilise the local market in terms of care market provision?
So I think it's too early to say, would be my view. When you say destabilise, do you mean around fees?
Absolutely, around costs. And self-funders have never been included in the mix before, have they? So that's putting pressure on the whole system.
Yeah, so it's likely that there will be an impact. And the impact will come around, will there be the rate difference between a self-funder and a local authority placed? And there'll be either an impact on the local authority and or the provider, not so actually on the self-funder necessarily. There's a benefit for the self-funder. So from a local authority and a provider perspective, we need to work that through and figure out how we manage that on the basis that we have a collective interest to have, you know, a good quality, sustainable market that provides good quality care, you know, and that. So we're going to have to find a way of navigating through those implications once they become a bit clearer.
Quickly.
Very quickly, on the 86k cap, that obviously is a figure that I don't understand where it's come from, but if you're a 24-year-old with particular care, complex needs, you've got to have that. Is that 86k cap applicable to that 24-year-old who he or she will see themselves through to exiting this world? I mean, it doesn't seem a fair figure given the types and numbers of people who will need care over the decades. And we know we have pressure on an ageing population. So I'm just really wondering where that 86k figure cap came from.
So the figure came from the government, but let me just sort of describe how that works for us locally. So it would be unlikely, highly unlikely, that an older person receiving care would exceed that cap. So if we take what we know about the lifetime cost of care for people in Peterborough, it's highly unlikely that cap will be breached. For working age adults, they will breeze through that cap actually quite quickly. And that clearly has implications. What's unclear is the sort of the minimum level, the means tested part minimum has been reduced from 23 to 20,000, but means tested from 20,000 to 100,000, and it's unclear about what that means tested looks like. So it is a concern for us indeed.
Councillor Farouk.
Thank you, Chair, and thank you guys for your report. Has been a consistent theme this evening regarding staffing levels and staff turnover. I was reading earlier today that even sort of pre-pandemic levels in social care across 18,500 organisations nationally, on any given day there were 122,000 vacancies to fill. And you know, the reality of this makes it far more expensive for providers or employers who sort of have to try and recruit constantly. And I just wanted to ask, sort of, in our local authority, how is our recruitment campaign and the Be a Care Worker campaign sort of put us in better position if it has across national? Thank you.
I'll ask Oliver to answer the question around the effectiveness of the campaigns, and I'd ask Carol to comment about, from a care association, what they're doing around the staffing, the workforce issue. And I will say, of all of the issues that we've talked about, I have to say that, for me, is probably the most significant issue that we're facing going forward. And we are, I think it's only fair to say that we are very, very concerned about it. And of course it's complicated because of the mandatory vaccination, which will have had an impact. The labour market generally is having a very significant impact on the care workforce. And what I mean by that is carers leaving the industry and going and working elsewhere. And that isn't just about the money, that there are other factors involved in that. For example, you know, career progression, for example, or lack of. There has been some funding announced over the last 48 hours from government around a workforce development fund, and we'll be talking to the care associations, because they represent all of our providers, about the best way of investing that money to help support the recruitment and retention of care staff. But if I hand over to Oliver to talk about the impact of the recruitment, and then Carol, if I may.
Yeah, thanks, Will. So the Be a Care Worker campaign, was something that we collectively worked on with our care association. We got the funding that Will referenced in terms of the Workforce Capacity Fund, and really asked the question of what would it benefit you as the organisations that are looking to recruit these staff. So we collectively issued this campaign. It warranted so it was £30,000 of investment. We saw quite a significant benefit in sort of the attrition rates of applicants. So in the first month we saw 200 applicants come in addition to what was already going to the various different organisations across the city. And of those attrition rates, it was a 10% appointment, which is, as I understand from our providers, was a really, really positive and higher than usual attrition rate. So I think positively, it's Will's just referenced the new workforce fund, a little over £500,000 for Peterborough City Council. We again are going to be in discussions with the care associations later this week to understand if it's something we want to sort of reiterate in terms of that, the Be a Care Worker campaign and build on its existing success, or is there something we want to tweak and learn from what we did last time?
Okay. Just to correct the number of shortages within the care sector at the time for medium and small businesses. Prior to the COVID situation, we were already running at circa 140,000 vacancies for care workers. That was without our qualified nurses. What we have had to do nationally is obviously we lobbied to get the healthcare assistants onto the shortage occupation list, which they now are. Internally within the country, we just do not have sufficient numbers in terms of staff to fill the vacancies both within the private sector or the NHS. Unfortunately, due to COVID, the vaccination scenario, many of the workforce that have refused to take the vaccinations have now gone to either the NHS or other sectors. We are concerned that due to the mandatory implementation of the vaccination again in April for the NHS, that will have a further knock-on effect. The reality is, as an organisation, we are not against the vaccinations. In fact, we promote vaccines. However, we have to be very realistic that the implementation of this mandatory situation has caused greater complications. And I talk from my own companies where we initially had a very high percentage of staff. In fact, 40% of our staff were refusing to have the vaccinations. But with continuous work, education, supervision, re-education and working with people, we got down to about 5% of our staff. And as we stand today, I think there are only 2 of our staff nationally that are leaving our company. So it can be done, and we're just saying it's not that we are against, and I think that there are many providers that are not against promoting the vaccination. So that is one of the aspects. In terms of additional staffing, we don't have the skill mixer numbers within our own country at this time. We haven't done enough work in the 21 years that I have been in the United Kingdom. I don't feel that we have done sufficient work to promote more people coming in, more of our youth coming into our sector. And it's a wonderful sector. But I don't think that we've done our work sufficiently to encourage this. And I talk as a nurse as well. I don't think that we've done enough. However, I also think that there are other issues that impact the staffing, and I know that everybody's hair will stand up as soon as I say finance, but we've got to be realistic. In 2019, we were saying that, you know, we needed a very quick cash injection of a very high sum of money in the 8 billion. Nothing happened. We haven't been financed appropriately to encourage people into our sector so that we could train them, and especially the youth. That is the reality of life, and we have to put that in our pipe and smoke it. As far as training is concerned, I do believe that the way in which we train our staff currently, university is a wonderful training environment to be in, but this is not assisting us in terms of numbers and people being trained and able or enabled to immediately implement their learning when they come into the sector. So I think the training is something that also has to be looked at, and the methodology, the way in which we are training our staff in universities, rather than, you know, if a nurse comes out of the university, some of them have to have a preceptorship for 2 years. That's just impractical within social care. Perhaps the NHS, because of their kind of funding, are able to sustain that, but in social care, we just cannot sustain that. Also, in terms of the recruitment, we are hoping that from a national perspective that the government will be listening to us, because we do need to recruit from outside of the country to enhance our numbers. However, what we are finding is with small and medium, and I'm talking about small and medium businesses, I'm not talking about the corporates who have the financial backup and the kind of funding because of investment to enable them to recruit like that. The small and medium-sized business cannot afford the cost of the recruitment. It can cost you up to £19,000 per nurse. For a carer, it can cost you up to £12,000. And if you're a small provider and you've got a 19-bed home or a 20-bed home, in order for you to recruit 5 staff externally of the country, it becomes an impossibility. So those aspects have got to be looked at as well in terms of staffing. I think it's also a culture differential in terms of the way in which we deliver services. I also think that when we talk to our colleagues in health, and our GPs and our pharmacists, we could do far more in social care than what we currently do in terms of the delivery of our services if the culture and the attitude would change towards social services. We don't have parity with our colleagues in the NHS. Although we are looked at, initially we were looked at as an unskilled workforce, I want to assure you, I'm very pleased that people have woken up to the fact that in fact our support workers and healthcare assistants are not unskilled. They're not an unskilled workforce, and more finances need to be input into the education of our workforce. As far as the going forward with the winter pressures that are coming now, we are afraid there are providers that are having to close beds. Peterborough, that is not the situation right now, I don't believe. However, elsewhere in the country it is. So with the winter pressures and the knock-on effect on the NHS, beds being blocked in the NHS, this could become an eventuality. And unfortunately, I have to say that if we don't have the staff, we cannot deliver the service. And the only recourse that we have as social care is, and the private sector, is that these clients would, the patients would have to stay in hospital beds. I will also like to say that I know that at one stage through COVID, there was work done on a designated facility that fell through due to a decision by health, which is a pity because that facility would have been 40 beds, which could have assisted in these times now because there could have been greater collaboration between health and social care to deliver in a designated facility like that. So there are problems, and we would have to face them. The only thing that we can do as medium and small providers is we are going to have to refuse to be able to admit, because we won't have the resource in terms of human resource to enable us to deliver.
Thank you, Carol. Councillor Kyle.
Thank you, Chair. It's going to be a brief question, actually, and sorry if you don't have the answer for this yet, but in relation to page 46.4.3.4, in which it's stated that there's going to be a 10% fee uplift, has that been given to providers or awarded to them already? And given the council and the local authorities' current budget position, is that something that will be maintained in the near future? I'd just like to say hello to Carol, because I looked after one of the nursing homes when I was a GP, and I'd really like to commend your staff, because during COVID, one of your managers said that she is not, despite not having PPE, not going to leave the residents in the state that they are in. So I'd really like to thank them for their service, and you as well. Thank you.
Yeah, so the 10% fee uplift was awarded last year. It was a temporary award for a 3-month period to enable providers to sort of have a level of sustainability until we could understand better the implication of the costs, and then take a strategy against that throughout the pandemic.
Councillor Emraj.
As a fellow healthcare worker, both working in the NHS and in private care, I'm a bit concerned on below 4.36, where it says workers age, the workforce and workers age over 55 represented 20%. So obviously, once you get to the age of 55 and past 55, it is really hard work looking after our vulnerable and elderly residents. What are we doing to encourage younger people to take up the post? Yeah, I'm glad that now care worker is being seen as a skilled work, because for many years it hasn't been seen as skilled. But we need to encourage those younger people to come into work. But with the wages being low, they're disappearing into other services.
Sorry, thank you. We cannot blindly stare at only the cost implications. And as a provider, we need to look at alternative means as well, and try our very best to encourage young people. So what we do is we do university placements within social care, and we're very proud that in Peterborough and in our supported living, we are one of the only services that do placement for mental health students from the Anglian Ruskin University. We also do talks. We do try to recruit within the universities as well, but of course our colleagues from the NHS also do that. Unfortunately, the benefits of working in the NHS far exceed the benefits of working in the independent sector, which is a shame. However, nationally, that is what we continue to lobby for and about, and it is our responsibility as a community to continue to lobby for that. Those are the measures that we are currently taking.
And finally, Councillor Farouk.
Thank you, Chair. I'd like to possibly apologise for this question, as I know it's probably not a nice one, but I feel I may ask it, or I have to ask it. I was reading reports really from other commissioners of local authorities nationally, and there seems to be sort of a slight worry that local authorities are simply buying packages of care sort of at the best rate possible, rather than focus on sort of a holistic and person-based approach, or trying to sort of shape or reform the social care market itself. So I just wanted to sort of hear your view on this, and then as sort of a part two, I know with the extra funding we're receiving, would you feel there's more funding needed to be allocated to sort of preventative care measures or preventative care itself? Thank you.
So on the first point, I don't think it's a horrible question at all. It's a very valid question, and so it's a delicate balance, isn't it, between price and quality, value for money. Our stance on it from a commissioning point of view is that we need value for money. If you benchmark Peterborough City Council spend and performance against other local authorities that are similar to us, our statistical neighbours, we perform really well, both in terms of the cost of care but also the quality of the outcomes. And that I think it's a mix of it's not just about the money, it's about the way and the relationships that we have with our providers. It's also about our social workers and their kind of skills and abilities, about the way services are developed with our providers. So for example, our focus is very much on prevention, or has been on prevention and early intervention, and that helps us delay people's needs from escalating, and that then saves us money that we can then that we've been able to reinvest back into other services. So I suppose our approach is value for money is really important, but it's not just about the cost of something, it's about what that something delivers later down the line. So I'll give you an example, if I may. We've got a fantastic reablement service, and we know that the cost to reable someone, when someone is discharged from hospital, to reable that person is just under £2,000. And we know that most people that go through the reablement service don't require any further support, and that further support might be home care, where the lifetime cost of home care is closer to £37,000. And so that's our approach, rather than focusing on getting too hung up on specific rates, although we do have to do that as part of our value for money. The real challenge, and I think the real benefit to us, has been thinking about the return on investment to the money that we're using, and that has come about through focusing on prevention and early intervention.
Thank you for that.
Well, thank you very much. It is recommended that the Adults and Health Scrutiny Committee note and comment on this report, which we have done. Well, thank you very much for coming along, and thank you for your reports. Thank you very much.
Thank you very much, and I'd like to thank Carol for your time. Thank you.
Agenda item 8, and the monitoring scrutiny recommendations. Paulina.
Thank you, Chair. This is a standing item, and it represents any recommendations that have been forthcoming from the committee at previous meetings, and if they are still outstanding. So we just have one recommendation on there at the moment, and you can see in the action taken that it's something that's going to be monitored going forward, hence why it's left on the recommendations report as an ongoing item. Thank you.
Thank you. Agenda item 9, the forward plan. The new latest revision was published on the 5th of November. Items relating to this committee is page 5, the adoption of the dynamic purchasing system. Page 16, PCC home care framework. Page 20, community alarm services. Page 31, health watch service. And non-key, page 33, innovation of dementia resource 70 contract. And page 38, variation to the delegation agreement between Peterborough City Council and Cambridge County Council. Anybody have any questions? If you have anything, that please get through to Paulina. Okay, and then item 10, the work programme. Paulina.
Thank you, Chair. Again, a standing item which comes to the committee at every meeting. It's an opportunity for members to make further suggestions which can be discussed at the group representatives meeting, and obviously to note any actions from this evening's meeting, which I have noted there were 1 or 2 actions that we might be asking for briefing notes or further reports on. So if there's anything else that you'd wish to propose tonight, or of course you can always email them through to me prior to the group representatives meeting. Thank you.
Okay, right, the date of the next meeting, the joint scrutiny is 17th of November. The next meeting of this committee is the 11th of January. Just before we go, I'd like to congratulate our colleague here, Charlotte, on the new Executive Director for People and Communities, which will start in January, I think, yeah. Whether she'll be at our meetings or not, I don't think she knows at the moment, but congratulations. And that is the end of the meeting. Thank you very much.